Good afternoon, everyone. Welcome to the community care session. Welcome as well to people who are online following. I'm Jasmine Menant from NURA, and I'm joined in by my co-chair, Daina Sturnieks from UNSW. So please take a seat. I just want to remind people when they're using Slido to start their question with the term community care so that we know this question is for our session. So this afternoon we're starting the session with Kelly Hopkins, a physiotherapist from Prince of Wales Community Health, and joined in by Fiona Conacher, and they're talking about implementing post-falls Huddles in a community setting. Welcome. So you'll have, each speaker will have 12 minutes and 3 minutes question at the end.
Thank you. Do I just press this one? Thank you. I have the honour of presenting this talk today on behalf of my colleague, Belinda Marshall, who couldn't be here today. We'll get going. And I'm Kelly. I'm a physiotherapist. I've been at Prince of Wales for 16 years in the community now. And I look forward to sharing our implementing post-falls huddle in the community setting, or we kind of sometimes like to call it huddle at home. And this is my manager, Fiona, occupational therapist. Just a little bit of background on TACP. So we're multidisciplinary rehab service, and we see clients over the age of 65 years old in their home post-discharge from hospital, and we do this for up to 12 weeks. We collect data and have been doing so for many years on witnessed, luckily very few, and unwitnessed falls, and then this gets analysed every year by Belinda. We then report this back to the team every April, and then we decide on some actions for the year ahead. So back in 2023, we agreed to implement the post-fall huddle as part of our falls management. They have been used in the hospital settings for several years, and we thought we would see how we go implementing it into the community. Okay. So just a little snapshot. Basically, the data's been collected from 2022 before we implemented the falls huddle, and then in 2024 after the huddle was implemented. And basically, it just provides a quick overview that in 2024 our clients were definitely an older cohort. We also took data in terms of their modified Bartel index, so their functional independence, and you can see from the graph as well that this was much higher, so sort of a much less able-bodied clients in 2024. This next slide, as I said, we've been taking falls data, we keep it on a falls register for many, many years. And basically the summary of this one, that we have quite a lot of falls, unfortunately. We had a lot of more admissions in 2024. Basically, of all the falls, you can see the average of our repeat fallers over the years is about 25%. And we can see on average that most of our falls happen in the first month of coming home. That's sort of sitting around the highest mark, and also we do have a very sort of repeat fallers, and that sort of tends to say around the 20% mark as well. Luckily for us, we don't have many witness falls, which we would have to put an incident in for, so we're quite lucky on that. But as you can see, it's sort of quite a busy slide, but we do keep a lot of data on our falls and try to improve those stats every year. So 25% fall again, 20% of admitted clients have a fall. Yeah. There's a next slide here that basically shows, as I said, most of our falls happen in the first 4 weeks of coming home. So the aims of this huddle at home was to implement the post-fall huddle in the community setting so that we can continue to improve our post-fall management in line with the Australian Commission of Safety, Quality and Healthcare and best practice guidelines. We wanted to improve our communication with our clients, their carers, and this would future contribute to their patient-centred care. We wanted to educate clients and their carers that falls are just not a normal part of ageing. So how did we do it? We established a local business rule for Prince of Wales TACP staff, adapting the CEC's post-fall huddle process for the community setting. So we used this data that we collect from anyone that had identified to us that had a fall in the community, and we pop it onto our post-falls register. We then analysed the data. As I said before, 2022 is the year before we implemented the huddle, and then the year after in 2024. So practically, how do we do this? We meet in the client's home with their permission as soon as possible after the fall. So basically that can be, I have a sort of an example where I was about to see a client, I got a call from the nurse, she was already doing a visit before me. She rang and said, look, Mrs. Smith's had a fall, are you around? I can see you coming over. So I went straight over and we completed the post-fall huddle sort of that day. That's not always practically possible when you're in the community. So what we often tend to do is make a time with the treating team. We'll call the next of kin, get the permission from the client to arrange a huddle the next practical possible time that we can do that. Even if we only get one or two clinicians present, one might be over the phone or a family member might be over a phone, at least it's sort of a collaborative approach to completing the huddle up form. So unfortunately, the data was inconclusive if it actually made a difference in the overall number of falls for TACP clients. But as we all know, sort of statistically speaking, we're dealing with quite small numbers, but we can also see that we have made quite a difference for some individual clients. We completed 33 huddles in 2024, and out of those huddles, 8 clients who had a huddle fell for a second time. Yeah, just checking. Okay, in terms of our results, we did a bit of a poll of the staff involved. So we collect this data, we have it, as I said, we bring it back and we all get together as a team and implement it. So then it was like, okay, how did everyone feel about the implementation? So we had a little staff poll. 100% of the staff had been involved in a post-falls huddle. 90% found that they were useful. 50% felt that there was client behavioural change. 50% found challenges in organising a huddle. As I said, in the community, it's not like we're on the ward and we can gather the doctor and the nurse and the OT and do it together. So there are some challenges. And 70% found that they learnt something from participating in the huddle. So to quote one of the staff, in my experience, the huddle has been useful for clients who've had falls when not using their walking aid. So it was really helpful to have a chat as a multidisciplinary team, client-centred approach, and they often use their walking aid after this, and this has been 100% successful to do that. Continue the results. Conducting these huddles at home is generally seen as valuable by staff and our clients, but we do use our clinical judgment to determine if the huddle is going to be beneficial for the client. We do have a lot of our clients with cognitive impairment that we it may not be beneficial. So as a team, we'd chat about the benefit versus risk of that one. So we use our discretion. We also, it depends if a client actually says, I don't want to huddle and I'm not going to tell you if I have any more falls. So we're like, oh, okay, won't do that. So yeah, we do use our clinical judgment from that. We've had some really nice light bulb moments for some clients. We did have one lady, she just kept tripping and falling, going to the bathroom at night due to poor lighting, but she had a vital call. And so she thought it was sweet that she just fell over and pressed her button, and her neighbour, who was on there, she thought that she was sweet to come and get her up at 3 o'clock in the morning multiple times. So after we had that huddle up, she agreed to get a sensor light, and that meant that her neighbour didn't have to get interrupted at 3 a.m. to come and get her, because she just thought it was normal that she was falling. So that was a really nice implementation that we were able to sort of put in for one of our clients. So in terms of the discussion, it is different doing a huddle up at home. I mean, there are lots of different inpatient to community, but we have done it, we are doing it, and we will continue to do it very successfully. We've seen a great shift on the focus of the clinicians and the clients, and as everyone knows, falls is everyone's business. We have nurses and case managers, social workers that are leading the huddle-ups, not just the allied health team. We do have some clients, a couple in the program a year, that fall multiple times due to medical conditions, and that can tend to skew the data. So in 2022, we did have one client that had cognitive impairment and needed supervision with toileting at night time. We'd recommended residential aged care, but the family wanted to keep her at home, so she had 8 falls. And then in 2024, we had a client with MS, recommended power wheelchair, but continued to use a 4-wheelie walker, and she fell 7 times. So a little bit of data to skew a little bit, but this is real, and this is real life and what happens in the community. But we didn't do a huddle up 8 times. We just used our discretion for those as well. So just continue on. Falls experienced by TSP clients are sort of, I guess, are in line with the expected rate of falls for our client group, especially in the post-discharge stage. I said that sort of that first 4 weeks of coming home. But maybe a part of us seeing a different or a large change in the fall numbers, maybe because we've already so amazing and proactive and providing good education and intervention for reducing our falls in our clients. So, go team. And in terms of future directions, this is embedded into our practice now. Everyone knows about it, or everyone is on board with it, the whole team, and we have the flexibility to use clinical discretion with our clients. So take home. It is really important to get staff buy-in. If your staff don't want to do it, it's not going to happen. And we feel like the process personalises the experience for the clients so that they are involved in their decision-making, and in terms of empowering them to feel like they're going to decrease their risk of falling, and improve that with them. Thank you.
Thank you, Kelly, very much. Do we have any questions in the room for Kelly? Cameron down the front has a microphone, so he'll send it backwards. I've got questions too, but you come here and...
Hi, ladies. I have so many questions, but I'll ask them another time. But just then you touched on getting buy-in from the team. Can you talk a little bit more about how you got the team on board with this and if there was any barriers to it? Thank you.
Yeah, I guess we're really lucky. We have a big team with a falls focus. I mean, our manager's passion is falls. And we really, because we've been collecting data for so long, everyone likes to see the nice results, I guess. Belinda also, who isn't here, who drove this, is again very passionate about falls. And I guess we work so collaboratively with each other that we sort of putting in best effort. And if the evidence says it works, why can't we give it a go? So And falls is everyone's business. It used to be that the physiotherapists and the OTs used to lead a lot of the falls with us, but we've actually transitioned that to everyone in our team does the falls risk assessments and the action plans. It's not just the allied health at all. So I think knowing their importance and their value in falls prevention is really, really important. And yeah, just a lot of encouragement, I guess. Yeah.
Hi, I also have a question. How did you determine if a client had fallen while on the service? Was this something that was prompted during the onboarding period where the MDT kind of prompted to ask questions during the start of their sessions? Because, you know, as we know, a lot of clients will fall and then not tell us. I was just wondering how you captured that information.
Yeah, great question. Sometimes they will come up with it, you know, very shyly, and other times there'll be evidence of like a skin tear or a bruise, and you can sort of go in with a subtle question like, oh, is that new? What happened there? I guess the important thing, as I said, with an example of, you know, if you make me do a huddle up, I'm not going to tell you. Just being really mindful not to make them feel like they've done something wrong or to make them feel bad about it. I basically just switching it around to be like, look, we just want to help you. We don't want you to have any more falls. We want you to stay at home. We want you to be safe. And let's have a chat about how we can continue to keep you independent, confident and safe at home. Of course.
From my experience as well, just for some of the clients to realise that it's not just their fault that they've had a fall, that there's all the risks that were mentioned this morning, like medication issues that they may not be aware of, and that we really have a big role in trying to break down that information and make it meaningful to the client. Lots of times that's very quickly delivered, and so they don't quite understand the impacts with medication as well.
Thank you. We're running out of time, but if this is a real quick question, yeah, go ahead.
I just answered the question that I was about to ask anyway.
Okay, well, thank you very much. So we'll move right along. Thank you both for coming up. Thank you, Kelly, for your talk. We have very swiftly moving along to our second speaker, Fatemeh Abdi. Fatemeh will give a talk titled The Availability of Falls Prevention Programs for Diverse Communities in Greater Sydney, a Gap Analysis. Thank you.
Good afternoon, everyone, and thank you for choosing to be in this room and listening to my gap analysis on the availability of falls prevention programs for diverse communities in Greater Sydney. I'm Fatemeh. I am a podiatrist and current MPhil candidate at the University of New South Wales School of Population Health, and I am researching falls prevention in culturally and linguistically diverse populations under the supervision of Professor Rebecca Ivers and Associate Professor Ben Harris-Rojas. So being here today, we all likely know the series of falls in elderly, being the leading cause of injury-related hospitalisation and death in individuals aged 65 and up in Australia. We know that data shows that 1 in 3 people aged 65 plus have a fall yearly, which can often have serious, long-lasting and sometimes fatal consequences for that individual. We probably already know that Australia's CALD, or culturally and linguistically diverse population, is continuing to grow. And there's already a large body of evidence on falls prevention in CALD communities, which is fantastic to see. But there remains a gap in understanding the availability and suitability of current falls prevention programs for these diverse communities across Greater Sydney, which is why we conducted this gap analysis. So the purpose of this study was to analyse and compare the availability of falls prevention programs in a range of local government areas in Greater Sydney by their linguistic diversity and socioeconomic disadvantage using the SAFER IRSD scores for each LGA. And then to also identify any disparities in access to these programs by CALD elderly populations. An audit approach was used to conduct this research, where data was collected for the 20 LGAs across Greater Sydney including their population size, elderly population size, SAFER IRSD scores, as well as main language groups, which would indicate the level of linguistic diversity in that LGA. 7 of the most and least disadvantaged LGAs were included in the study, as well as 7 of the most and least linguistically diverse. We then collected all publicly available information on falls prevention programs being offered in each of these LGAs through searching their LHD websites, the Active and Healthy website, as well as Google to identify any private or community listings. These were the included LGAs, which we ranked based on their levels of advantage to disadvantage, with Woollahra being ranked as the most advantaged and Fairfield as the most disadvantaged. And similarly, Sutherland Shire comes on top as the least diverse in terms of language diversity, and Burwood Council coming up as the most diverse in terms of language diversity. We then categorised the programs based on whether they were government supported and being offered through the LGA's local health district, or as listed on the Active and Healthy website, or if they were being offered in private practice, which would often include physio clinics or other non-government private organisations. We then gathered the total number of programs being offered in each LGA and put these on column charts to study the patterns related to SAFER IRSD scores and language diversity. What we found was that on average, the most disadvantaged LGAs offered fewer programs when compared to the least disadvantaged with comparable elderly population sizes. For example, Campbelltown and Ku-ring-gai LGAs both have comparable elderly sizes. Ku-ring-gai ranks amongst the top 7 least socioeconomically disadvantaged, while Campbelltown ranks amongst the 7 most socioeconomically disadvantaged LGA. Ku-ring-gai offers 16 falls prevention programs, while Campbelltown only offers 3. A similar pattern is observed when we look at language diversity and program availability, where the most diverse LGAs offer an average of 6 programs, while the least diverse offer an average of 8. Let's take a look at these results more closely. The blue bars represent the least disadvantaged LGAs, and the orange bars represent the most disadvantaged. You can see a general pattern where program availability compared to elderly population size, which on this graph is represented by the dotted line, is far greater on the left for the least disadvantaged than it is on the right for the most disadvantaged. We can see the same pattern again when we compare program availability by language diversity, where again the blue bars represent the least diverse and the orange bars represent the most diverse. There is far more program availability when compared to elderly population size for the least diverse LGAs compared to the most diverse. Let's take Canterbury Bankstown as an example on this graph. It has the highest population of elderly out of all of the LGAs, offering 9 programs, compared to the Northern Beaches, which has the second highest elderly population size, offering 19 programs. Canterbury Bankstown ranks amongst the 7 most linguistically diverse, while the Northern Beaches ranks amongst the 7 least linguistically diverse LGAs. Another important point is that there was only 1 program being offered in a language other than English, and that was in Chinese/Cantonese in Gordon, Ku-ring-gai LGA. That was the Stepping On program. All other programs were in English. And just a reminder again that Ku-ring-gai is amongst the least socioeconomically disadvantaged. So there are 2 main things that we take away from these results. One, that there actually aren't that many programs being offered in LGAs that are more socioeconomically disadvantaged and linguistically diverse. And 2, that they are not culturally or linguistically appropriate to meet the needs of the diverse residents that live there. And just a final point that Campbelltown, Liverpool and Fairfield were identified to be the most disadvantaged in terms of program availability compared to their relatively large elderly population sizes. So the findings of this study highlight significant disparities in the availability of falls prevention programs across Greater Sydney's most and least disadvantaged and diverse LGAs. Our analysis shows a strong link between demographic factors like socioeconomic status and linguistic diversity and the way healthcare resources are allocated by both government and non-government sectors. The most underserved LGAs were located in West and Southwest Sydney. These areas had some of the highest proportion of elderly residents, yet the fewest programs available. This pattern aligns with the 2021 Dropping Off the Edge study, which identified suburbs within the least socioeconomically disadvantaged as having the best indicators of health and well-being. So this brings into focus the difference between equity and equality in healthcare, because when we look at it from a distance, some of the most disadvantaged and least disadvantaged LGAs offer the same number of programs, but the most disadvantaged LGAs have significantly higher elderly population sizes, and they also have more diverse communities, which means their residents might have more specific needs. Our findings also show a critical lack of culturally and linguistically tailored programs. Many CALD communities face not only limited program availability, but also significant barriers in accessing them. Things like language barriers and low health literacy, amongst other factors. And this is further complicated by the fact that public health websites often don't offer language options, which further excludes CALD populations. So these gaps highlight a clear need for targeted investment. To address the disparities identified in this research, we need targeted policy and planning that prioritizes investment in CALD and socioeconomically disadvantaged LGAs. These communities have higher needs but fewer services. Equally important is cultural tailoring. So programs must go beyond just translation, and they have to take into account cultural sensitivity by building trust, respecting cultural norms, and ensuring that facilitators reflect the communities that they serve. Digital access, especially in this day and age, also matters. So key platforms like LHT and the Active and Healthy website should include multiple language formats to make programs more discoverable and accessible for older adults with limited English. Finally, future research should not just explore if culturally tailored models work, because we know that they do, but how they work best and in what combinations. Testing these approaches systematically will help scale what works, close equity gaps, and support healthier ageing for all. As with all studies, our study had a few limitations. One was that we used broad language categories to identify culturally and linguistically diverse communities, but this may not always reflect the full cultural differences and the needs of each group. We also relied on online searches to find falls prevention programs, which means we might have missed some that were not listed online, but this probably still reflects how most people, especially elderly and their families, would try to find these services in real life, so it's still a realistic approach overall. In conclusion, our findings show a clear mismatch between where the need is greatest and where services are being offered. Disadvantaged areas, which often have large CALD populations, are being left behind when it comes to falls prevention programs. Without programs that reflect people's cultural and language needs, we risk deepening existing health gaps. Ultimately, if we want to reduce falls and support healthy ageing, we must ensure that programs are available and appropriate for the communities who may need them the most. Thank you.
Thank you very much. Any questions for Fatemeh?
I'm walking. Oh, I've got a question too. How did you define what a fall prevention program was? And also, when you took into account how many programs there were, did you take into account how often they ran during the week?
Absolutely. So I have a big supplementary data to support the presentation today. Basically, we define a falls prevention program as any program that's specifically focused on balance and exercise. The frequency of the programs, as much as there was publicly available information, I did record it in the table, but not all of them were very specific in terms of, we don't even really know whether some of them are active, but again, this is just publicly available information at this point.
Thank you.
Thank you for the presentation. I wanted to ask, has this study been used to show more of a need and an increased rollout in certain programs in certain LGAs?
So at the moment, this study is actually under peer review, but ultimately that is what we aim to do with the upcoming projects.
Thank you.
I've got one question. Just wondering if you think the digital apps, like the Standing Tall app, for example, that can be translated in many languages, could help fill in a little gap?
Potentially, but then there's also the consideration that there is often low levels of health literacy, even amongst, even if you translate the material into their own language, there might still be difficulties with access due to that.
If we have time for one more, Jasmine? Thank you for that talk. It's really important, obviously, that we highlight the disparities. I wonder whether, did you present anything about the programs that are publicly or privately provided? Because I wonder whether that accounts for the disparities, or somewhat accounts for the disparities. But excellent work, and to lobby for more programs.
Absolutely.
In those areas.
So we researched publicly available information on both private and public programs, but our search was limited on online data searches. So if there were programs being offered privately in clinics that were not listed online, we probably missed it in this study, which was one of the limitations.
But you did have some private providers
Yes.
in your study, and so what proportion, and was there a bigger proportion in those less disadvantaged areas?
We actually found that government-supported programs were not, it was equal amongst the most and least socioeconomically disadvantaged areas, but overall private listings were more than government-supported. But that's not to say they were government-funded, just being offered through the LGS LHD. But in general, private practice offerings were more than government-supported programs in all LGAs.
So it's a issue of equality or equity, isn't
Absolutely.
it?
Yeah. Thank you. All right. Thank you for your time.
Thanks very much. We move on. Next speaker is Frerik Smit. He's a graduate student from the Sydney School of Public Health at the University of Sydney, and he's going to present to us a systematic review of socioeconomic position and falls among middle-aged and older adults. Thank you.
Thank you. Well, thank you so much for that last presentation. It relates a lot to this topic, as you can see. So it's a great pleasure to be here today to present the work from my master's thesis of my MPH, where we did a systematic review on socioeconomic position and falls. Before I continue, I would like to acknowledge the traditional custodians of the land that we are meeting on today and pay my respect to all elders past, present, and emerging. So I don't think to this audience I need to give any background about the importance of falls as a public health issue, but just to give a bit more overview about the social determinants of health. I think a lot of people here will be quite familiar with the fact that health inequities, both between and within countries, have been widely established now, and this has a lot to do with socioeconomic position, so I'll call that SEP a lot in this presentation, and this refers to the social position that people have within society based off of various social and economic factors, and this can be education, occupation, employment, housing, and so forth. And when it comes to meta-research related to older adults and middle-aged adults as well, systematic reviews have looked at the relationship between SEP and healthy aging and frailty, but to our knowledge, the existing evidence on the relationship between SEP and falls has yet to be comprehensively synthesized in a review, so we wanted to fill that gap. And one thing we also wanted to look at was the extent to which the existing literature has looked at SEP at different stages of the life course. So we produced the protocol for the review, which is registered in Prospero, but we also wrote a full protocol article, which is now published in BMJ Open. So if you want more detail about the methods we planned on taking and also the justification for those methods, those are published online, and the actual manuscript for the actual review is currently under review. I won't go into detail, but just to give a brief overview of the methods, we searched 3 databases from March 15th from inception to March 15th, 2024, with search terms and mesh headings related to socioeconomic position, falls, middle and older aged adults, and also observational studies. And we included observational studies that had a mean or median participant age that was above 40 years of age. And studies had to have results on the association between at least one SEP indicator and one falls outcome. So in terms of study selection, one reviewer, myself, screened all titles and abstracts, but a second reviewer screened also 20% independently. And I think we had 95% agreement. And then full texts were screened by 2 reviewers independently. The data extraction was done by one reviewer, but all of it was cross-checked by a second reviewer. And then in terms of data synthesis, while we did plan on doing a meta-analysis, there was a lot of heterogeneity across studies, so we had to narratively synthesize results, and then we also used a modified QUIPS tool for the risk of bias assessment, where we added items on over-adjustment bias from Robbins E. Now, one further note on the methods, and I don't want to get into too much detail about this because it's a bit technical, but feel free to ask questions about it at the end. We knew from the offset, before we did any searches, that we were likely to find a high number of risk factor and predictive modeling studies, simply because there was a good chance that these types of studies would have at least one SEP indicator included as a potential risk factor or predictor in their predictive models. But the issue with this is that those estimates, they're meant to be risk factor or predictors and not etiological effect estimates. So we didn't want to overly interpret the results of these studies, and certainly not the same as studies explicitly aiming to study SEP and falls. So what we decided to do was to only include these studies if they reported unadjusted results or also minimally adjusted results. So these are essentially just regression models where there's a small number of covariates that are clear confounders. In the prime example of this, it would just be adjusting for age and sex. And so along the lines of that logic, we decided to report results separately for studies explicitly aiming to study SEP and falls, studies not explicitly aiming to study SEP and falls, but that did have some of these relevant minimally adjusted results, and then these other studies where there was only unadjusted results that we were interested in. So the study selection flowchart is up here. As you can see, there was quite a lot of search results, but we narrowed that down to 125 studies. And of those, 14 explicitly aimed to study SEP and falls, 9 other studies had some relevant adjusted results, and then the remaining 102 only had relevant unadjusted results. So study characteristics of all 125 studies, most were cross-sectional, published after 2010, had a majority of participants that were older adults and also female. So now going into the actual results. So these are of the studies explicitly aiming to study SEP and falls. And what we did was we created a visual presentation of the results where for each indicator, which is each column, we indicated what studies had results on that indicator. And then we also color-coded that and also shaded according to statistical significance. So on the legend in the bottom right, you can see that the orange coloring is for studies that showed an adverse association. So this was where higher SEP was associated with a higher risk or rate of falls. The gray coloring is for where there was mixed results or no association, and then the blue coloring was for studies where protective association was found. So that is where higher SEP is associated with a lower risk or rate of falls, and then the darker shading is for statistical significance, the lighter shading is for results that aren't statistically significant. Now overall, when you look at it, I won't go into detail on each indicator, but in general there's more blue than there is orange, so that does indicate that generally speaking across SEP indicators, higher SEP is protectively associated with falls, but the results are mixed, and a lot of them lack statistical significance, and some results show that an adverse association appears to exist. Now, the 9 studies that, again, did not explicitly aim to study SEP and falls, but did contain some relevant adjusted results. There is, again, more blue than there is orange, but it's a lot of light blue, and as you can see, education has far more results among these studies than any of the other indicators. Now moving on to the remaining 102 studies. So these again are studies that did not explicitly aim to study SEP and falls, but did contain some relevant unadjusted results. And the visual plot that we created here is a bar plot where the bar represents the number of studies that have results on fall outcomes for that SEP indicator. And as you can see, education has far more than any. Of the 102, there was, I think, around 85. And then in terms of the coloring of the bar, so the orange part of the bar is for studies where falls were disproportionately high in the high SEP group. So in an unadjusted regression model, that would be where higher SEP is associated with a higher risk or rate of falls, again in unadjusted results. The gray part of the plot is where there were mixed results or no difference, and then the blue part is where falls were disproportionately high in the low SEP group. So this would be where in unadjusted regression models, higher SEP would be protectively associated with a lower risk of falls. So in general, as you can see, there's quite a lot more blue than there is orange or gray. And in fact, for each SEP indicator, there were at least 50% of studies that showed that higher SEP, that falls were disproportionately high in the low SEP group. So this does suggest that in general, in unadjusted results, fall inequities exist across indicators of socioeconomic position. For the purposes of time, I won't go into detail here, but like I mentioned earlier, we were interested in seeing the extent to which existing literature on this topic had looked at SEP at different stages of the life course. And quite glaringly, out of all 125 included studies, only 4 had any results of a SEP indicator that was explicitly from a life course period prior to the study period. And this was generally retrospective prior occupation measures, so it wasn't great either. Now, what are the key takeaways of all of this? So in general, the overall existing body of evidence on the relationship between SEP and falls is quite limited. So we had 125 included studies, but again, only 14 of those explicitly aim to study SEP and falls. They have mixed results, some results indicating the opposite, where SEP was adversely associated. There were some risk of bias issues, and for each SEP indicator, there was a maximum of only around half a dozen studies with results for that indicator. Some indicators had no results. But in general, within that limited body of evidence, higher SEP is generally associated with a lower risk or rate of falls, but again, it's from a very limited body of evidence. But when we look at all 125 studies and just the unadjusted results in those, it is quite clear from these studies that falls are disproportionately high in the low SEP group across SEP indicators. So then in terms of the implications for this, well, again, like I said, the evidence on the relationship between SEP and falls is very limited. So there's not enough, so to speak, causal or etiological evidence to say that if we were to increase people's socioeconomic position, say increase their education or their income, that would then translate into reduction in the rate of falls. It's very possible that that would be the case. I suspect it is, but we don't have enough evidence to say that. At the same time, it is quite clear that fall inequities do exist and that falls are disproportionately high in low SEP groups. So it would be appropriate, I would say, to consider implementing fall prevention interventions specifically targeted towards groups and individuals of lower socioeconomic position, and that can include implementing exercise programs and promoting physical activity. But again, historically speaking, there's a lot of barriers that lower SEP individuals and groups face to engaging in those types of activities, so that those barriers would have to be tackled as well. In terms of future research, there is quite a clear need for more research on the relationship between SEP and falls, and ideally that would be done in a causal framework, but that is very difficult in social epidemiology with social exposures. But studies do also need to cover a wide array of different measures and indicators of SEP, so not just education, because they all matter. And then mediation analyses to understand the specific pathways between SEP and falls would be quite useful as well, because then we can identify the specific pathways between SEP and falls, and that can lead to ideas for new interventions and where to act. And then finally, like I said, there was quite a glaring knowledge gap with regards to life course SEP and its impact on falls at different life course stages. So future research should look at that as well. Now, before I finish, I would just like to say a big thank you to the entire authorship team on this project. I'm sure you'll recognize some of the names there. It was a pleasure to work with all of them, and yeah, thank you so much for your interest. And if there's time, I'm happy to answer any questions.
Thank you for that very nice talk, Frerik. I really enjoyed that. Can I start off? while Cameron's finding the next question. Right up the back, Cameron, go for a walk. You showed something about the proportion of studies that came from the Americas, but I'm just wondering about the studies that were included, what parts of the world that they came from, regions of the world, and do you think that your measures of SEP are equivalent across those different regions? And presumably you had a much higher proportion of higher income countries represented.
Because to make it all fit on the slides, I just put the biggest proportion, but yeah, most were from high income countries, and it was the Americas, North America specifically, and also a lot from Europe. Mm-hmm. In terms of SEP indicator, we just took what kind of was in the studies. And for some of them, as you'll know, they have some international standardized classifications for education and so forth. So for some of those, that would be standard. And I guess education years is another example where education years is quite an objective measure, but whether the quality of the education is the same varies. But then income would be relative, occupational class would be quite relative between countries. And that I would say is very important to look at, but it's difficult when you have so many different studies and to make it all fit.
Yes, hi. I'm an occupational therapist. I saw on your chart that housing was unequivocally, the low SEP was completely represented and nothing about the high SEP. With the housing, did it say in any of the studies what particular factors? Was it the fact that the housing was tenuous, that it was unsafe?
Yeah, so
we've all got housing on the brain at the moment because of what's happening tomorrow.
Yeah, so with regards to housing, one thing I should note is that there was a lot of studies that had things related to housing, but like trip hazards in housing, but we decided not to consider that as a socioeconomic position indicator. So we looked more at things like house value or the things along those lines, but evidently there weren't that many studies that had that. But there were, I would point out, quite a lot of studies that had like dangers within the home or fall hazards within the house, but we didn't include that. So I don't, off the top of my head, have the results that those studies showed.
Did it say anything about the crowded nature of housing?
I believe some studies had that, but we didn't consider that as a SEP indicator. So again, I'm sorry, I can't.
No, that's all right.
I don't have any results for that.
Thank you.
Yeah, time for just one more question. Thanks.
Thank you, Frerik. How did you differentiate high versus low SEP?
Yeah, okay, so what we did was most studies had it categorized, which was quite useful, and along the lines of what a lot of reviews have done, we just looked at the highest versus the lowest. So in binary variables, it was quite easy, it's just high versus low, but in categorical with multiple categories, we just looked at the highest versus the lowest as classified by the authors of those studies.
So in terms of like net worth,
yeah, so wealth had nothing, but in terms of income, sometimes they did like deciles, or they did quartiles, or they had like certain categories of, say, above 100,000 to 75K, 75K to 50K. Education, it would be like tertiary education versus like obligatory schooling. For occupational class, so like manual labor jobs versus white-collar jobs, so to speak, things along those lines.
Thank you.
Okay, we're out of time. Thank you so much, Frerik, again. Really nice talk and great data. And it might have been nice if we had have scheduled that one before Fatemeh's talk, but anyway, it was nice that your work sort of goes together nicely. So I'd like to introduce the next speaker now, Adam Buckingham, physio at the RPA Hospital. And Adam will talk about fall service at Camperdown. Thank you.
Thank you, everyone. My name's Adam, and as introduced, I work at RPA Hospital, and probably first of all, I work as part of a team, and I see a lot of familiar faces out here, and it's really crucial to be able to do this job with a multidisciplinary team, given the complexity of the clients and patients we work with. Firstly, as well, I'd like to thank Raymond Weatherall for his welcome to country, and also recognise that I work, live, and we're presenting at the moment on Gadigal country, but I also work on Wongal and Bidyagal country. I pay respects to elders past, present and emerging. Why is a falls clinic important? In terms of potentially preventable hospitalisations, it's a bit of a buzz term at the moment. It's really important to realise, I guess, as part of what I do when I step out of the building that I work, I look directly at ED, I see the ambulances, and I always remind the students that I've got is that's why we're here, that's why we get paid. Our job is to try and prevent those falls, those injuries, those presentations, and maybe admissions to hospital. And also very important is the quality of life, not only to our clients we see in the community, but also their families. And the other thing is I'm very privileged to work in prevention. It's a very small area when it comes to therapy, and I realise how important it is as a prevention and as a tool and how effective it really is. I work with a geriatrician, Associate Professor Mark Latt, and I work in a small team as well with Ciara Warsop, who is coordinating a number of clinics for specialists, including the Falls Clinic, and handles referrals. And I, as a physio, work part-time in this service, and I work in another service as well, which I'll talk about shortly. In terms of our roles, the geriatrician I work with runs a clinic on 2 half days of the week. The other days, importantly, he's working on the wards in his role in terms of geriatrician and closely with the advanced trainees. Myself is predominantly associated with home visits, although I do see occasional Falls Clinic joint sessions with geriatrician or for clients who don't want to be seen at home. The inclusion criteria, there's a lot of detail there, but realistically, it's frail elderly fallers is who we see in the community. Obviously, it's younger for the Indigenous community. They need to have had a fall. It's our primary predictor of the future, having had a fall. And so that's the most important thing. In terms of cognition, there's some flexibility there. If someone's got a carer or a family member who can assist with the implementation of the education or the exercise, we're very flexible and look to see how we might implement our strategies with them. The exclusion criteria, I guess in terms of physio as part of my role, is really if someone's receiving an equivalent type of service. That might be, for example, DVA Gold, it might be high-level home care package, or it might be transitional aged care package. I tend to see my role and what we do as a bookend service, and I mean either we're seeing someone before they're presented to hospital having had a fall, or we're treating someone after they've been through the journey in hospital and been treated and are back to baseline and need some work in terms of falls prevention. The service that I provide is limited, particularly around the Camperdown area, and that's associated probably with the old local governments of Marrickville and Leichhardt, which is mostly inner west now, and also part of the City of Sydney. If someone's in a residential aged care facility, I don't see them individually, although I have been in the past asked to come in and provide in-services to their staff, which I'm happy to do, to try and promote falls prevention in a wider sense. When to refer? As I said earlier, it's really someone who's frail. Really, groups are more associated with those who are more able. In terms of clients who are inpatients, it's not appropriate. They're still on their journey through the hospital system and getting their workup. And I have to be careful because I've often been seen as someone who, if TACP is not available, they'll think of me. But really, if someone's not at baseline, it's not my remit in terms of trying to get them back to that point. Medically, all the referrals, or nearly all the referrals, come via the GP, and GPs are overwhelmingly receptive when we contact them about medical workup. There occasionally is some referrals to the geriatrician from specialists such as cardiologists. And it's usually via fax in terms of medical, or in terms of myself, it's through the Access Care team, and that can be done via the intranet, or it can be done by the 1300 number you see in front of you. As I said, it comes really via the GP, and it's usually one of the things I find as part of my role is I actually don't sit in the physiotherapy department. I sit in with the community workers, and I mean older people's mental health. I mean ACAT. I mean home-based therapy in terms of physiotherapy, occupational therapy, speech pathology, dietitians, chronic care teams, Aboriginal chronic care teams. My job is so much easier by working very closely with them. The conversations I have in the corridors make a huge difference to what I'm able to achieve for my clients. I'm only part of what the clients need, and I recognise that and work closely with those other therapists. What's really important that I've identified in our current model is that our doctors or geriatricians, as part of their ward rounds, will pick up if falls is an issue. It may be not even part of their current presentation as an inpatient, but identifying the fact that there's a falls issue that can be remediated by them. This is very important because at the moment I've done a secondment, I continue there part-time in another role where I work in another falls clinic in another hospital where the specialist hasn't got that access and hasn't got the richness in terms of referrals. I get a lot of my referrals from my geriatrician and vice versa, but again, it's a whole team approach. If you're part of Sydney Local Health District and want to refer to physio falls-wise, you can do it through the district-wide services, then through the Aged Health Chronic Care and Rehabilitation Service. There's a link and the phone number. You have to complete all the yellow sections on the form. The form doesn't always work. I suggest you take a printout of it, scan it and send it through to Sydney Local Health District ACT or Access Care team, and they'll look after it. What's my journey been? It's been 10 years, maybe 11 now, in terms of working in the full service and attending these clinics, forums. And the work that I do is predominantly in the community as part of RPA, but my second role has given me a much broader perspective recently because I work in ED. I work in ED at Fairfield Hospital, and when I'm not working in ED, I see the patients who come in at home and follow them up individually. I also work with an Indigenous able and stable group called Auntie Roma's there. So I'm a bit unique in that I'm a clinician who works in ED inpatients in the community and also touches on residential aged care facilities. This has given me a much greater understanding of what's going on in terms of the system and where the gaps are, and I'll talk about that towards the end in terms of where our service is looking to go. Now, with the referrals, medical-wise, it's about 3 months. It might be 30 days or a month if it's urgent. In terms of for physiotherapy, for me to see someone, it's a quick acting type of service, so usually within 6 weeks, and the amount of time I need to see them depends really on the individual. It can be a one-off, it may be a couple of sessions, it might be weekly, it might be every couple of months. It just depends on what they need. Who's appropriate and who's not? When I think about someone who's maybe fallen, they're living alone at home, and as a result of a couple of recent falls that they've had, they've started not going out anymore, they may be only making it to medical appointments, that's someone who's appropriate for my type of service. Someone who maybe still be working, driving, a lot more active, I tend to think would be better off suited to one of the group type of sessions. So it might be an able and stable type of session, or it might be a stepping on, one of those type of programs that are being run for the less frail. One of the big, I guess, moments I had when I read the falls prevention paper, white paper for New South Wales 2023, it made me think about what we're doing in falls. And one of the big things and messages that came through is it needed to be more coordinated. So instead of working in islands or silos in our own particular discipline or in terms of our own geographic region, we need to branch out. I've done that personally by seeking a secondment in another district, and the amount of information that I've learnt has been enormous. And I guess that's one of the things about this forum. It's about talking to others, building networks, using ideas from other areas that you can use, lessons that I've learnt that we can implement or avoid. Now, one of the areas for our particular section we're looking to focus on in our team at RPA is probably not so much in terms of more resources, because there aren't any. It's about making or using the time that we have more effectively. We've had a look at some studies, particularly one by San Juan et al. 2024, that looked at falls presentations to ED who are directly discharged home. Now, for someone who presents to ED and is admitted, they'll get medical workup, plus or minus allied health, what they need for their journey. The problem's been, now that I work in ED and still do, it's a case that there really, is there any red flags there? Are there anything acute that needs to be managed? If not, return back to home with no follow-up. And I believe this is the area we are missing in terms of gaps, in terms of our patients, and a priority for our type of service. We're looking to work more closely with the emergency department in the future to identify this cohort of patients. How we treat them, I don't know yet, but I suspect the numbers are there, and we're going to work in this particular area to see what we can find, because we tend to think this is a higher level of priority patient that's been missed. Still, I'm going to still persist in trying to increase some of the services that we've got, and I say that because we've had a reduction in the amount of allied health across our district in falls in the community. But it's going to take a business plan, it's going to take a cost economic analysis, and I'm asking anyone out there who's got any ideas or experiences with to help me and my team with that, because there isn't many good examples to use. Things that I think are really important. Home visits. The amount of information you learn is crucial. You need a broad, open mind perspective. Be embedded amongst the community workers. You need to sell the idea of exercise to people. It's easy when you explain to them that you can get stronger, your balance can get better, because there's not many things in life that do get better with age. Use a tailored approach, and one of the things is to avoid the term mechanical. We see it in ED. As a physio, I need to drill down to the root cause of that. Is it length of muscle? Is it a gait disturbance? Is it a neurological condition? Is it vision? We need to drill down to the root cause. I'll skip over this. This is one of the patients that I was seeing. Very complex, but we're able to get some great results. Any questions?
Very much. We've got time for one question, one or two quick questions, please. Any questions? I've got one. I was just wondering, you mentioned that sometimes you might see people twice or you might see them regularly. What determines the end of you seeing them? Is it when they're able to join?
It really runs out when I'm not able to give them anything new or different, and I do try to graduate them off either to an independent exercise program at home or to another program via group, but it's got to be lifelong exercise.
Anyone else? All good? Well, thanks very much, Adam, and we'll keep moving. Next speaker is Melody Leung, a PhD student from the School of Public Health Institute for Musculoskeletal and Health at University of Sydney, and her talk is on a protocol for implementing a structured priority setting process for falls prevention research in Australia, an interest holder-driven approach. Thank you very much.
Thank you so much for the introduction. Hi everyone, I'm one of the PhD students from the University of Sydney, and today I'm really grateful to be given this opportunity to share the protocol of one of our very exciting study on implementing a structured priority setting process for fall prevention research in Australia. And I do want to acknowledge that this is still a protocol and a lot of details of this project are still developing, and that's one of the reasons why we still want to present in this conference today to actually get the input and feedback from the floor. So feel free to ask any questions at the end of the presentations. But before that, I would like to give a brief explanation of why we would like to start this study right at the beginning. And one of the reasons it's because although we know that there are a lot of evidence-based fall prevention interventions nowadays, however, it seems like that falls among community-dwelling older adults in Australia are still quite prevalent. And that probably implies that our evidence-based practice is actually not being successfully translated into our real-world practice. And one contributing factors to this could be because we rarely identify the research priorities from our key interest holders that might have an impact on fall prevention. And therefore, if we are able to get the input from these key interest holders right before we even start our research, then it's more likely that any results or any evidence-based practice derived from the research will be more likely to be translated into our real-world practice. And that's the reason why we wanted to do this study with an aim to collaborate with different key interest holders to generate the priorities for our future fall prevention research in the Australian context. And to be more specific, how are we going to generate these priorities? It's actually through implementing a structured priority setting process. And this process here will therefore form the major method that we are going to use in this study. And I guess most of you here would not be too unfamiliar with the term priority setting because we are basically setting priorities in our everyday lives. For example, attending a conference today, listening to these presentations is probably one of your priorities. However, particularly in research, there is a specific term called priority setting partnership. So what does that mean? It actually refers to bringing all the patients, carers, and clinicians together to identify and prioritize any unanswered questions in a specific area of healthcare research. And basically, the idea of the whole process here is to bring all the relevant key interest holders together to ask them, what do you think is the most important thing that we should focus on in our future research? And in our particular case here, it will be fall prevention research. Now, the reason why this process is a structured process is because of the use of the James Lin Alliance methods here. And why is this method a structured process? Because it provides us a step-by-step guidance to identify the priorities from our key interest holders. And that includes a summary of 3 steps. So first of all, we need to develop a collaboration with our interest holders, and followed by identifying, summarizing, and ranking the priorities from these interest holders, so that lastly, we can come up with a strategic research agenda to address these gaps that are being identified from the interest holders. Now, not only is this method a structured method, but I do want to emphasize that this method is actually strongly driven by interest holders. Why is that? I'm going to explain it in more details in this following slide. So in order to have an approach to be driven by interest holders, obviously the first step is to recruit the relevant interest holders first. And that could include, for example, patients, carers, and clinicians. So once we have recruited all these relevant key interest holders, we will then move on to step 2, where we will identify the priorities from our interest holder through the use of surveys. And this is this step here that reinforces the fact that this is an interest holder driven approach. Why? Because not only do we ask them to respond to the surveys, but we also ask them to develop and analyze the surveys at the same time to come up with a final top 10 priorities. And once we get these top 10 priorities, we will be able to move into step 3, where we'll develop a strategic research agenda. It is strategic because it is specifically targeting at that top 10 priorities identified from the interest holders to address those research gaps. Now, hopefully now we understand why the whole process here is actually a structured process and strongly driven by interest holders. But now you may wonder, how do we exactly achieve this? And therefore, I need to give you a little bit more details about step one. Not only do we need to recruit the different relevant interest holders, but we actually need to divide them into two different groups. And the first group is what we call a steering group. And the second group is a survey respondents group. So what does a steering group mean? It's actually a representatives of the different types of interest holders that are relevant to our research. So in this case here, if we are aiming of a total of 12 representatives to form the steering group. And in these examples here, we have 3 different types of interest holders. And approximately, we are going to have 4 representatives that represent each of the 3 types of interest holders here. And their main role is to develop and analyze the surveys only without completing the surveys. And therefore, on the other hand, the survey respondents will be completely external to the steering group that will only respond to the surveys without developing or analyzing the surveys itself. And therefore, you can see that I intentionally put the 2 groups in 2 different colors, one in orange and one in blue, not because they are my favorite colors. It's hopefully, by dividing them into 2 different groups, it helps us to visualize how we can actually achieve this interest holder-driven approach in step 2. Because the details of step 2 here is that, first of all, we will have our steering group, orange in color, to develop our survey at the beginning. And this survey will then be distributed to our survey respondents. And once we get the responses from the survey respondents, then the responses will then be sent back to the steering group so that they will analyze and summarize the responses into a long list of priorities. And that this long list of priorities will help us to generate another survey, which is a ranking survey that goes back to the survey respondents to ask them now to rank the top items. And therefore, ultimately, we will send everything back to the steering group to summarize and revise them into a shorter list of priorities that help us to come up with ultimately the top 10 priorities that we want, and ultimately help us to generate this strategic research agenda to address the research gaps. Now, hopefully now we all understand what a James Lin Alliance method is and why and how it is a structured and interest holder-driven approach. And this is exactly the method that we are going to adopt in this study. However, I do want to emphasize that this is just a framework, and as with all the other frameworks, there is always room for making modification and changes, and therefore this is an adaptable framework. So meaning that we can use the principles based on this framework, however, the details of each of the steps here is always subject to refine. And therefore, as part of the collaborative processes in step 1, it is to actually communicate with all the identified interest holders to understand, is there any specific things that we actually need to modify, change, add in order to make it more feasible and suitable to our Australian context. Some examples could be, for example, instead of just including patient carers and clinicians, we may need to include policymakers as well, or culturally and linguistically diverse populations and indigenous communities. And because of the potential of including the diverse populations, we may also need a translation of different surveys, and we may even have follow-up phone calls in addition to the surveys. Or in the end, we may simply even use interviews over surveys as well. However, these are all suggested changes, and these are not finalized until we have communicated with our interest holders. However, regardless of the details of each of the steps here, the most important thing is that this will be the framework that we are going to use in this study. And hopefully, the expected results based on the use of this framework here is the following 3 deliverables. So after the first step, we hope that we are able to come up with an adapted method together with our interest holders to be able to identify a method based on that principles from the framework that we can apply it to our Australian context. And secondly, we'll be able to come up with a top 10 priorities through that consensus building process where the steering group and the survey respondents work hand in hand together. And finally, that we are able to come up with that research agenda to address the research gaps that we identify from the interest holders. And because of that strong interest holder-driven approach that I have been emphasizing throughout the presentations here, hopefully this research agenda would be able to reflect the voices from diverse populations in Australia to meet the community needs in the area of fall prevention research in our country. And ultimately what we want is this community-informed research agenda to be able to support the translation of our evidence-based practice in our community through, now that we are able to direct our research efforts into a more high-priority area that is being determined by diverse populations in Australia, so that we can support a more equitable healthcare resource allocation to facilitate the implementation of our fall prevention evidence in our community setting. And ultimately, what we want, obviously, is to be able to enhance the success in preventing falls of our community-dwelling older adults and improving their overall quality of life. Now, before I finish off the presentation today, I do really want to acknowledge all the investigators that is already on board in our team. But as I said that because this is currently still an early stage of our project, we do need a lot more voices, opinions, and more different types of interest holders to join our group. And therefore, if you're interested in this study, feel free to contact us via the email here, or simply just fill out this expression of interest form by sending the QR code here that you just need to provide your emails if you do think that this is a wonderful and meaningful project that we can work together in the future. Thank you very much, everyone, for listening. This is the end of my presentation.
Thank you so much, Melody. I did notice that you didn't have policymakers or researchers in your interest holders.
Yeah.
Is there a reason for that? Can you elaborate?
Yeah, so that's correct. So currently, as I said, this is just a protocol, so therefore a lot of things is actually not yet finalized. There is definitely a flexibility of including a policy makers as well. And to be honest, we in our investigators here, there is already a representative for policy makers. But in terms of researchers, there is also a flexibility of including them. But one reason why we don't want to include the researchers we may not include the researchers in our steering group is that we want to make sure that the whole process is actually driven by the interest holder itself, but then the researchers is actually kind of providing the support and facilitating the whole process. But then there is, again, the room for adding a researchers into that steering group, but then based on the previous research, normally it's no more than 2 non-researchers to 1 researcher ratio to make sure that there is not many biases involved in making the community-informed decisions. Yeah.
Thank you. Any other questions? Melody? Okay, well, just quickly, I was wondering about how researchy these research priorities are, or are they much more applied or practice or translation type of activities, not just research, pure research?
Yeah, definitely. So the whole idea of doing a priority setting is actually having to involve the different populations, the diverse populations from the community to help us inform what do we actually need to do in our future research, rather than just from the researcher's perspective to think about what we are interested in, and then in the end coming up with a results that actually may not be something that our community wants. And therefore, part of the reasons why we need to do a priority setting process is to understand what is required in the community, and therefore we can better devise our research agenda and to come up with a research that will better suit the needs of the community, and therefore translating the research from our research into a community setting. Yeah, so
that pleased the people in the front row very much. Thank you so much, Melly. We're out of time.
Yeah.
Thanks for your talk.
Thank you.
Our next speaker is Natalie Narunsky. Natalie will talk about stepping on with recovery. Natalie is an OT from South East Sydney Local Health District. There you go. Where are my words? Over here.
Oh, shit, okay. Yeah, okay. Wow. Okay, hi. So today we're going to explore the intersection of mental health ageing and falls prevention, and why this has been a priority for our service. The organisation chart that's displayed shows the relationship between all members of the older person mental health team. Each discipline is expert in their area, understanding physical, cognitive, and mental health problems of our consumers and their medical treatments. We are all providing professional mental health evaluation and treatment and all the care plans with our consumers. The service is guided by the principles of recovery, consumer-led care, and partnering with consumers, family carers, GPs, and other key service providers and supports. And using occupational therapy skills, I support consumers experiencing cognitive decline, mood disorders, and complex realities of aging, all of which significantly impact their daily functioning. One of the most significant and often underestimated risks in this population is falling. Genuine acknowledgement is directed to Megan Swan and to Lindy Clemson for providing the science and research behind this evidence-based program, which incorporates strategies of adult education, principles and reflection to implement positive lifestyle changes, to equip participants to remain independent and active, stepping on inclusion criteria for those people living independently in the community with or without a walking stick and who have had a fall or have a fear of falling. Exclusions include people with cognitive impairment or degenerative neurological conditions, or those dependent on a walking frame or live in assisted living facilities. We've heard today about the fall rates in residential aged care facilities, as well as the incidence of falls in hospitals. In our general population, 1 in 4 people over the age of 65 is likely to fall at least once a year, many more often. Amongst older people with mental health conditions, this rate is even greater. A fall can trigger or worsen anxiety, depression, and even lead to a long-term functional decline. High doses of antipsychotics and sedatives to minimize harm or harm to self or others, to minimize aggression. Also ECT, electroconvulsive therapy to treat severe depression or mania are all associated with an increased falls risk. Side effects like dizziness, lowered blood pressure, orthostatic hypertension, decreased alertness, and sedation are all indicators of a higher risk of falls. Depression, delusions, hallucinations, decreased attention, racing thoughts, slowed or chaotic thoughts, all influence behavior and increased risk-taking, which can contribute to increased falls risk. Among those with severe psychiatric illness, there's a decreased self-care, which can influence falls risk by malnutrition, dehydration, and muscle atrophy. And given the clinical importance of a fall and its implication on treatment, there is a need for a targeted falls prevention program for consumers of our mental health service. And that's why facilitating this falls prevention program has been so valuable in our community. Receiving a mental health diagnosis can bring about significant emotional and psychological distress. There's secrecy, stigma, shame, judgment, fear, alienation, desperation, and misinformation. And this can have considerable negative impact on the individual's life. This lack of meaningful community participation leads to negative perceptions, fatalism, deconditioning, loneliness, and disempowerment, all of which are predictors of both physical decline and increased falls risk. Predictors of falls in people with mental health condition helps us better target intervention. Many are treatable or modifiable factors which position us to intervene early and effectively. And this includes the attention to environmental hazards, medication management, vision, hearing loss, diet, all which contribute to safer mobility. Older adults with mental health conditions are significantly more likely to experience falls. And this isn't just due to because of overlapping due to aging, but because of overlapping physical, cognitive, and emotional vulnerabilities. Our focus is how we are going to break this cycle. One of the most critical yet under-addressed issues is the lack of appropriate community support and activities for those with mental health diagnoses. Activity centres and bus outing attendance doesn't really work because they don't account for the fluctuation of cognition or moods or motivation. People fall through the cracks, literally and figuratively. The Stepping On with Recovery Falls Prevention Group primarily addresses falls prevention education program, as well as social isolation and loneliness, which is so prevalent in consumers of our mental health service. It offers a bridge between clinical care and community re-engagement, building confidence and reducing fear of being in a space with others. Social connections are encouraged and assist with combating isolation. The program supports autonomy, recovery, and hope in mental health care, using a variety of learning strategies, including opportunity to share their story, which encourages the development of a group process. Our falls prevention education group targets modifiable factors, encouraging safe behaviour. It increases knowledge and skills for preventing falls, both in the individual's home and in the community. It's tailored for this population, focusing on psychoeducation, confidence building, and mobility training, and all that within a supportive group environment. The 7-week structure, together with the booster session, aligns with the principles set out by Megan Swan for facilitating a Stepping On group, utilising specialist guest speakers for educational presentations and adult learning opportunities for participants. Referral or recruitment to Stepping On with Recovery differs, as well as group facilitation technique, which follows the principles of personhood and recovery. Limiting the group size to 12 participants with acknowledgement that there will be at least a 10% drop-off rate supports a close-knit gathering and small group size of people to re-engage after periods of isolation. Unique to the Stepping On with Recovery program is a weekly phone call, which maintains the motivation and commitment to group attendance. And it's during this call that, I can't see where I'm up to, sorry. It's during this call that participants are able to talk about their affective symptoms that they're experiencing, and attention is also given to the queries about the information from the week's guest speakers. Oftentimes people are too shy to ask a question or to talk about something, and also to go over the exercises that have been set in the homework book. Distinctive too is the inclusion criteria of measuring of mood, and also introducing a cognitive activity related to the theme of the week and the guest speaker, as well as the introduction of a psychologist to talk about the value of having psychological therapy. And this may be the only friendly phone call that they receive during the week, besides a scam call or somebody doing an election survey. And this is a really big social skill to try to develop. As with all groups, composition and dynamic differs from group to group, which is the joy and challenge of group work. The group represented in the current slide shows that the youngest is a female of 68 years old and the oldest being a male of 90. Unusually, there are more men than women in this group. And the attendance, we would have expected, I said earlier, a dropout rate. And this was astounding that there was really, people were fully committed. They came to each session. The absentees were related purely to life events like attending a funeral or illness. And the group comprises of community dwelling, older people with mental health consumers, including those who are close to discharge home from the Euroa mental health ward, which is an inpatient ward. They may or may not have physical health comorbidities, but they do have one or more psychiatric diagnoses, either anxiety, depression, mood, elevation, psychosis. And also present in the group are those who are experiencing carer stress, isolation, or loneliness. I'm going to flip through these quite quickly because you're all aware of the screens that we're doing. And what you can see is that the reduction in time indicates an improvement. We're talking about a higher than 13.5 being of a high risk, and you can see that the group still remains within the higher than 13.5. However, what their take-home message is that they are now yet more aware that they are a falls risk. We also are able to observe the postural stability, the gait, the stride length, and sway, which may signify neurological problems and that may require further evaluation. We can also see if people perhaps should be using a frame for walking as opposed to saying, I'm fine the way I am, holding onto the wall. The strength and balance measures, again, the reduction in time shows not much improvement, but there are some small improvements. And again, the lesson here is that they are much more aware that they are a falls risk. Here we have the strength and balance measures, and most participants made improvement with at least one leg. I've only represented 6 over here because the other 4 did in fact have 30 for both legs in their 30-second standing, and we don't do the eyes closed test. But of interest for us is the benefits of the mood tracking, and participants are asked to rate their mood, with 0 being the worst possible mood and 10 being the best possible mood. And this is recorded at the start when people walk into the session and before they leave again. Participants are encouraged to consider their overall mood, including any positive or negative emotions they may be experiencing, such as happiness, sadness, anxiety, anger. There's always quite a lot of anxiety of getting people to have left home in order to attend the group. And when people arrive, it's like, yeah, I've made it, I've done it. Sure, let me sit down. Measuring mood levels on a scale of 0 to 10 can be a useful tool for tracking changes in mood levels over time and assessing the effectiveness of interventions aimed at improving mood. And it's important to note that this method of measuring mood is subjective and can vary depending on the individual's perception and their mood. And it helps clients to practice recognizing the link between their emotions and the environment or the situations that they have influenced them or the situations that they are in. But attending this group showed an increase in the person's perceived value of their mood rating from the beginning till end. And it prompts the person to be aware of triggers that assist to better manage their lifestyle choices, make informed health decisions, prevent or avoid the triggers of negative methods, and work towards a better quality of life. So morning tea. In addition to the structured falls prevention education program, facilitating social interaction during the informal tea break between exercise and education components offered a valuable secondary therapeutic benefit. Social engagement in this context played a critical role in enhancing mood and reducing feelings of isolation and fostering a sense of connectedness among the participants. These informal interactions create opportunities for peer support and shared experience, which can positively influence motivation and self-efficacy. This style of engagement offers equity to people with mental health diagnosis. Participants who feel a sense of belonging and interpersonal connection are more likely to attend consistently and complete the full program, and thereby increasing the overall adherence and optimizing the therapeutic outcomes in the group-based interventions. A sense of improved mood and perceived social support promotes sustained engagement. So we had cake, fruit, cheese and crackers, gluten-free or kosher options were always offered. Hot beverage orders were taken right at the beginning of the program, so we knew which person wanted what, with 1 or 2 sugars and so on. So it became like a restaurant feel for the people sitting around the table. And all of this for a mere cost of about $250 over a 7-week period, which includes paper plates and napkins. As the group comes to an end in session 7, we work with each of the participants, providing them with options so that they can work with an area in their local areas. There's follow-up with our social workers to assist with registering people with emerged care and with obtaining the correct codes for the services that they require. And they enjoy the connection and familiarity of the group, but they do need hand-holding to go further, to branch out and to attend another session. The lack of confidence and poor motivation being the major barriers. From a strategic lens, the program aligns closely with hospital goals, preventing avoidable admissions, promoting integrated discharge planning, and building community capacity. The value of this group goes beyond its physical safety. It integrates cognitive strategies, environmental adaptations, and most importantly, person-centered education that empowers individuals to understand their own risk and build confidence in their mobility and mood. By delivering this as a group, we reduce isolation and promote peer connection, two powerful protective factors against depression and anxiety. It creates holistic care and provides falls prevention education in the true sense of a recovery framework. Incorporating person-centered and trauma-informed care for the hospital, this translates to reduced falls, fewer unplanned admissions, shorter lengths of stay, and improved quality indicators. And for the person, it means they can stay at home longer, regaining independence and feeling safe in their own body again. We've taught them how to get up off the floor if they do fall at home. They don't need to call the ambulance. In addition, the consumers who've provided feedback after attending these groups, it's been enlightening to hear their feedback, but also from the specialist educators. Many are, and I do ring them all before they come to prepare them for the group that they're going to attend. Many are hesitant when they first walk into our Euroa building. They're very nervous, they're dubious of what they're about to encounter, but by the time they leave, they are overcome with emotion. How do you do this? I've never enjoyed the group so much. This is my favourite group to present to for the repeat educators. And as seen by the testimonials, as occupational therapists, we're uniquely positioned to connect the dots, tailoring strategic strategies to each individual's routine, environment, and mindset. We're not just supporting falls, we're preventing it with falls prevention education. We're supporting autonomy, dignity, and quality of life in a world where people are being ignored, feared, and misunderstood, and all because of what's going on in their brains. The additional secondary gain of the opportunity to socialise in a safe, like-minded environment is what participants are rating highly. Falls prevention is important, but groups such as these are essential in the care of older adults with mental health needs. Also just to thank Libby, Powell and Tegan from the Equity and Prevention Service, Population and Community Health, because they supported us right up until 2024 when the program was cut. But to my manager, Daniela Canaric, also thank you for providing the creative source of funds that keep our program going. And the picture you're looking at is one of Margaret Olley, which I saw recently at an exhibition that I went to. And for all those occupational therapists out there, I'm sure you'll find what I loved so much, seeing what she's wearing around her neck at that lovely age. So thank you.
Thank you very much, Natalie. Unfortunately, we really run out of time for questions, so please catch up with Natalie at the end of the session. Thank you. And our final presenters are Queeny Stafford and Nadia Williams. They're both Stepping On coordinators, and they're going to present to us Stepping On Falls Prevention Program Priority Population. Thank you very much.
Thank you very much. I'll have this mic nice and low for shorty me. Hi, good afternoon. Thank you for staying around. I'll get right into it. So, as you all know, while we know that falls prevention programs and interventions are well researched and already implemented, there is a challenge of how do we ensure that vulnerable populations aren't left behind. We know that people that experience disadvantage suffer more worse health outcomes. So, and as most of us are probably tax-funded services funded by the government, we have a responsibility to make sure that vulnerable populations don't get left behind. So I'm hoping that, I really invite you all to think about how can we make our services more equitable for those who don't have the access, power or means. Some of you might be familiar with this diagram about the difference between equity and equality. Equality is giving everyone the same thing. Equity is making sure that people that need it more are supported to achieve and thrive. And luckily at our organisation, we have an equity framework that supports our work that we're presenting today. So what we did, we literally just picked up a phone, called our local social housing service and asked them, would you like to work with us? We identified that in our district we have about 6,000 dwellings that are owned by social housing providers such as Link Wentworth, Bridge Housing and St George. Within each dwelling there's probably maybe 2 or 3 people living in there, but from our conversations with these social housing providers, we found out that they estimate about 60% of their residents are aged 55 and over. They report social isolation being a big issue in their community. Around 50% of their population speak a language other than English. Digital literacy, health literacy are generally pretty poor. If you think about a lot of our digital programs, universal programs, a lot of them are moving online. And a concern about this is not everyone has access to an iPad or a laptop. They don't even have private space to do telehealth. So it's really something to consider when you're planning your program. And as we know, transport can be a challenge. A lot of them don't own cars and rely on public transport. And so we, to our knowledge, we, after speaking with these 3 providers, we established an Ageing Well in Social Housing network. Previous to that, our understanding was those 3 providers had never gotten into a room, like a virtual room, so we meet online. They had never collaborated before on the subject of health and wellbeing. So we brought them together and decided to work on 3 priorities, being healthy ageing, falls prevention, healthy eating, and social connectedness. And that aligns really well with some of their goals that they're trying to kick as well in the social housing sector about sustaining tenancy and keeping people well at home. So I'm going to pass you on to my colleague Nadia, whom I forgot to introduce, I'm so sorry,
okay,
stepping on coordinator, who will talk about what we actually did. So.
All right, yeah, well, I think that Natalie gave a lovely description of stepping on.
My name's Queeny.
Oh, Queeny, by the way. Yeah, Natalie gave a lovely description of stepping on, so I won't go into it in too much detail, because I know we're running short of time. But what we did was we did present stepping on to these housing partners, and we said to them, look, you know, when falls are usually the beginning of all the kind of health problems that kind of affect older people as they go forward, and this is a really good place to start. They first and foremost saw themselves as landlords. They didn't see themselves as sort of health providers. They liked to put a few programs on now and then, but they didn't really consider themselves a vehicle for anything more than that. And anyway, when we said we sold stepping on to them, and very well, because it was really basically 2 meetings and we were up and running. They said, yes, let's do it, let's run with it. And they used all their networks to contact all the consumers and everything within their service. And so we were also able to use some of our other arms, because we do a lot of culturally and linguistically diverse programs in northern Sydney. We're currently running Korean, Cantonese and Mandarin programs. So we put those within their settings as well, put those in their way, so they're very excited about all of that as well. Okay, we know that especially with the cold populations, there is a large cold population within social housing, and we know that with our cold programs, we're quite unique in that we run them all completely in the language of the group. We hire and train facilitators who are bilingual, who speak the language of the group, and they present the information. So there is no interpreters. It's done purely for them, and it's a very, very good way to sort of cut through a lot of the misinformation, and etc. So we had, I've just lost my place. Okay, we know that a lot of the, many migrants, they lose a lot of their information, their independence as they become reliant on family for a lot of their information and for transport, and the inability to speak and read English is a barrier to social interaction, and that can lead to a lot of loneliness. Despite the availability of numerous language organisations, they're not even aware of them, and so this is a good way to make people more aware of what's out there and how to get involved with it. So Stepping On has been a fantastic venue for that. Also, it cuts through the problem of digital literacy. So the cold population were very easy to engage. The English population, not so much. They did come, but they came in dribs and drabs. We thought we'd be inundated at first, but we weren't. We had probably 2 or 3 out of the housing department came along to every program. The rest were from the greater community, but gradually that number's increasing. And I started a group yesterday, and it is chock-a-block with housing tenants, which is different. And we've only been going for 9 months, I think, with this program, and yeah, so it is increasing in popularity. The word's spreading, and people are coming along. Okay, so we're learning that it didn't happen overnight, but it did happen, and we're getting to work with some really, really great people. We're working now with other agencies, such as not only social housing, but with Oz Harvest, with, who are the others, the Aboriginal services, I'm just trying to think. We're doing pretty well in those spaces, so that's pretty good. We've had some great feedback, not only from the tenants themselves, but also from the people from social housing. They're very, very happy with the way things are going, and they've been great partners in that they've been putting on social programs for their tenants as a result of Stepping On. So they're doing, there's a yoga group started, there's a Tai Chi group started, there's another strength and balance class started, and that's all being funded by the social housing people as a result of kicking off this push towards good health from Stepping On. So it's been very, very useful and good all the way through. What else can I tell you? That's probably it. You want to do the summary there, Queeny? Yeah.
I missed a slide.
I'm just racing.
No.
Okay.
So, it's not working.
Yes. Oh, you haven't moved. Oh, that was what you missed that one. Yeah. That's one of our Chinese groups. Cute. Okay.
So we put a little bit more words on the slide, so if people want to have a read of it later on, or people that are online, they have some more context. So in summary, I think what we've demonstrated is that a Stepping On program, we know it works, so how do we make sure that it reaches populations that usually miss out? They might not know about it, and it's taken that, so what we have done is created really strong partnerships with the program coordinators and the engagement officers at each social housing, and they have taken it upon themselves to really proactively engage with their tenants who are usually hard to reach. They're sending SMSs out to tenants, telling them about the program, so things that we didn't even think of. So I think it's been a really valuable partnership. We've demonstrated that it's a soft entry for people to access other health services as well. There'll be services that they didn't know about, and that peer support has encouraged each other to access services that they didn't know about or didn't have the courage to access. I think the Stepping On program also overcomes the digital exclusion that might occur with other programs. Making sure that people that need that face-to-face support don't miss out. I think one of the strengths, positive outcomes, is the collaboration we've seemed to have fostered among the social housing. Nothing like friendly competition. Some of the providers were more advanced than others, and so when they see that, they go, okay, how can we lift our game? And we're sort of still in early phases of this collaboration, but what we hope in future is that we expand to other health priorities, and that it can have influence further than just Northern Sydney. And just on the slide there, here are some partners, and we must acknowledge the our funding partners as well from the Primary Health Network. They've commissioned our services to deliver more services to priority populations, so we must acknowledge their support with that, and all our social housing partners. Also acknowledging Margaret Armstrong, who's not with us today. She's over in the UK, and she's our who looks after this program, but she's in the UK. And thank you very much, and happy to take questions or chat to you after and connect with us.
Thank you very much, Queeny and Nadia. I think we do have time for a question. I mean, we're running late, but it would be only fair to give you some question time, because you did finish on time. There's one here. Cameron, if you can run that back. Kathy Sherrington has a question. So come back here.
Oh, okay.
Congratulations, that's so exciting. I just wanted to find out a little bit more about the kind of funding arrangements and, how you'd actually managed to make that work.
Well,
we not still, too rude.
Well, we still have our healthy ageing funding, that we've been getting from the ministry, which is nice, and a lot of the programs are being funded through that. But the PHN have been very kind, and they've been wanting us to deal with some of the priority populations, like the non-English speaking and the Aboriginal groups. So they've been very generous in giving us some lovely money there. And as you could probably appreciate, the called programs do take a lot more resourcing to get set up. However, you only need to do it once. You don't. Once we've got everything printed, translated, all the publicity material all available, and we've trained all the facilitators, because we don't only train the facilitator that runs it, we also train all the guest speakers, because we use bilingual guest speakers for everything. So it's very, very pure in that language, and very culturally appropriate all the time. So once we've got all that training and that behind us, that's what we use the funding for, then we can just continuously run them, and we've got all the team in place. So it's been really good like that.
Yeah, and I think it's like a matter of setting it up, and now hopefully in the future it's just business as usual. It becomes our usual practice.
Yeah. We ran a lot of them before COVID. We had 5 cold groups before COVID, and so now we're back up to 3, but we're hoping to get back up to where we were before. So, yeah, there we go. Thanks.
And hopefully some capacity to expand to other areas as well, because, as you say, once you set it up, then a lot of the work and resources.
Well, we've got some of our facilitators here. They might be keen on travelling.
Very good. Well, unless there's any other burning questions for Nadia and Queeny, I might, there is, right down the front. We've got a couple of minutes. It does mean that we're going to run into the next session, but let's use this time. Yeah.
Actually, you pointed out something really important, which it comes to how we can extend these type of programs to other areas. I'm from Canterbury, Bankstown, and we are divided into 2 local government health areas, and I find it extremely difficult to move, especially if it's just one street. One of my seniors is only able to access this and the other is not. So it would be really interesting to see how we can work that, because we are one country yet it's so different. And some of the other presenters were talking about the disparities amongst the low socioeconomic areas and coal communities. So I would really like to probably ask a challenge to see how we could do this to everyone.
Be great. Well, we're obviously happy to share our resources. We always have been. We're not sort of protective of them. We've got everything translated and ready to go, and all you'd have to do is change the badging on it. But But look, you know, Megan's over there. She's providing stepping on training to people, and if you've got people that are bilingual and wanting to work within their communities, etc., well, pop them along for training, get them trained up. We can definitely give you all the resources we've got in our arsenal. We're very happy to share because we'd like to see it spread as well because it's so effective. We have such great uptake of the call programs and I'd love to see that happen and just call me. Oh, there's my thing. No, it's gone now. It'll be in the thing. So definitely. Okay, thank you.
Thank you. Great to know that you're happy to share the great work that you've done. So these sessions are being recorded and I think they'll be up on the network website, so you can get back to Nadia's number, hopefully, the slide on the number. But thank you everyone for joining this session. Thanks especially to our speakers.